Good afternoon, everyone, and welcome to our Lunch and Learn. I'm just going to go back one slide in a moment here, but wanted to let you know that we are recording this and we'll be posting it on social media and or YouTube at a later date for people who couldn't make it today to see. So just as a heads up, if you would like to change or hide your name, or anything like that so that it's not visible, please go ahead and do so now. And I would like to welcome our three panelists today, Tara Gomes, Corey Ranger, and Natasha Twinard. Hopefully I got that right in the moment. Thank you for joining us. Really look forward to hearing what you have to say today about this topic. And from here, we've got our recording. Just to let you know how it's going to go, the presentation is going to take approximately 30 minutes. It may go a little longer than that. And then afterwards, we will be doing questioning with our panelists. If you do have questions, if you can type them into the Q&A field at the top, we won't be taking live video questions. And then that way, Dr. Janetta Salvalaggio, who is our moderator today, can keep track of them and we'll be going through them in order. We are also on Facebook Live, and so I'll be monitoring that. If you're coming to us from there, for any questions that come through there, you can just type them in the chat and I will pass them on. And so without further ado, I'm going to pass you over to Dr. Salvalaggio, who's going to do our land acknowledgement and get us started.
Hello, everybody. Thank you very much for joining us. I am logging in from Weskwachewan, Edmonton, Alberta, Treaty 6 territory. We are located, of course, in a land that has diverse peoples, including the Cree, Métis, Nakota Sioux, Iroquois, Dene, Inuit, Blackfoot Confederacy, Tsuut'ina First Nation, the Stoney Nakoda, and many others whose histories, languages, and cultures continue to influence our vibrant community. And I recognize that many of you may be logging in from other areas on Turtle Island, and I encourage you to think about on whose territories you are sitting and working today. We respect the histories, languages, and cultures of all First Nations, Métis, Inuit, and First Peoples of Canada, whose presence continues to enrich our vibrant community. Specific to this session, the Opioid Poisoning Committee, of which I co-chair for the Edmonton Zone Medical Staff Association, has been on a journey over the last few months of wanting to listen and learn what to do and how to support people who are affected by the drug poisoning crisis in our role as physicians. And so we come to this conversation again today with that particular perspective. We are here to listen and to learn. We are not here to unilaterally prescribe recommendations, but to understand the wisdom from the real experts. And so we've gathered some of them with us today to share their knowledge and their wisdom with those of us in Alberta who are seeking a way forward. So for today, what we wanted to do is define what safer supply is and what it isn't, understand how safer supply models are provided in a Canadian context, apply lessons learned from Canadian safe supply providers, researchers, and people who use drugs, and figure out how we might apply these in an Alberta context. So I've asked our panelists to think on a few opening questions in their presentations, and each of them are going to spend about 10 minutes in turn. What is safer supply? How do safer supply programs work? How does safer supply address the drug poisoning crisis? What are the benefits and the risks of this approach for both individual people who use drugs and communities? How can any risks be mitigated? And that was just some opening suggestions. I am really looking forward to their respective perspectives on this. Without further ado, I'm going to hand the mic over to Natasha Twinard to start us off, who's coming to us from the Canadian Association of People Who Use Drugs Today, and also from our East Coast. So over to Natasha.
Thank you so much. Yeah, it's great to be here with you guys today. First, I'd like to acknowledge that I work, live, and play in Mi'kma'ki, which is the traditional, ancestral, and unceded territory of Mi'kmaq people. I also recognize and deeply respect the histories, contributions, and legacies of the African Nova Scotian people who've been here in this province for well over 400 years. So for the Canadian Association of People Use Drugs in 2019, we wrote the first safe supply concept document within the country to spark this conversation. And how we define safe supply is it refers to a legal and regulated supply of drugs with the mind and body altering properties that have traditionally been accessible only through the unregulated drug market. Those drugs can include opioids, or must include, I should say, opioids, considering that's what's killing us now, as in hydromorphone, diacetylmorphine, stimulants such as cocaine, methamphetamine, and benzodiazepines. So currently, most of us probably here today know that we're in the worst overdose crisis in Canada's history. Recent numbers came out from Dr. Teresa Tam and the Public Health Agency of Canada, where we've noted that 20 people a day are dying due to a drug poisoning crisis, one that we've been unable to address fully because of the inaction of moving safe supply forward. And most of these deaths, worth noting, are mostly due to fentanyl analogs, but more recently, even non-pharmaceutical benzodiazepines and other adulterants. And so the government of Canada even said, I think it was in 2018, they had a quote that the overdose crisis has existed for a long time, and it's a reality that is likely to stay for the long term. Yet the need for safe supply existed long before the current overdose epidemic. And so that quote rings true with our agency. And so for the very reasons that most are apprehensive, I would ask people to really consider that, you know, in a drug poisoning crisis, if it was any other type of a poisoning, we'd be able to retrieve whatever was poisoned. Let's say lettuce, for example. If there was lettuce that had listeria on the shelf of the grocery store, we'd be able to retract that. We'd have a response. But because we don't address the crisis and because we don't address what's happening, there is no response. And there's pockets of different programs that very well try to and do a really good job. And I think you'll hear that from my other colleagues that will speak with me today. But for far too long, actually for decades, my community has been forced to risk overdose, poisoning, infection, STBBI, disease transmission, and death, because we have no other choice but to rely on an unregulated market. So moving forward, there should be meaningful and purposeful expansion of the provision of safe supply and regulated drugs to compete with the unregulated market, which will significantly curtail these harms and is a necessary step moving forward to the crisis that we are amongst. Why is it so important? It's based in our human rights because prohibition-based policy by nature is dehumanizing and degrading to people who use drugs, but not just us, but to society and humanity. As the people that are suffering, it causes and affects the least most fortunate among us to suffer all of these consequences. And historically, prohibition has been a tool of stigmatization, but really I say the verb of stigma is discrimination. And it's predominantly against people who are poor, impoverished, Black, Indigenous, women, and parents. And morally, we're blamed morally worthy for our choice to consume drugs. But yet, policy, medical societies, doctors don't recognize that this is not something that's new. People have used drugs since the beginning of time. And so for the fact that we think that it's just going to go away because there's policy in place, it's not. And so we have a duty as individuals in our society, moreover, doctors, to be able to recognize that OAT is not for everybody. It doesn't meet the needs of somebody perhaps that has been using unregulated fentanyl. And so for those very reasons, us as a society have to be able to meet the needs of the community that is underserved, overlooked, and discriminated against. Safe supply will change the narrative by respecting the autonomy and agency of individuals who choose to use drugs, removing labels of moral blameworthy with respect to our drug using behavior. The provision of a regulated supply is a necessary step to end tyranny, criminalization, and discrimination, sorry, as I said earlier. It's also rooted in justice, because when we think about who is imprisoned right now in our country, predominantly Black and Indigenous people and women. And so for those very reasons, we're doing a disservice to our community to understand that, you know, marginalized communities are facing that we're suffering in this country. And we're allowing it to happen as individuals that have the ability to change that narrative. So let's talk about the effectiveness. Well, different interventions, as I said, work for different individuals, OAT being one of the tools that we've used for a long time, which, if you remember, was a very contentious thing when OAT was coming into intervention within treatment and was disputed against. And so I would ask people, if we look back at history and we look at the apprehension that we have, that we now know works for a certain part of our population, that doctors are free and safe to prescribe daily. Why is safe supply so controversial? Why aren't we trying to meet the needs of individuals in our society that otherwise every day risk death or overdose or with other, different harms that they'll experience? Because overdose death is the worst, but there's other things where people experience hypoxia of the brain. There's all kinds of different nuances to this crisis. And the very fact that most of us are unwilling to accept that this is here, not, as I said in the beginning, not for the short term, for the long term. Humans have used drugs since the beginning of time, and sometimes for pleasure, but other times it becomes because of our, social determinants of health, trauma, not being housed, and all kinds of other reasons where people have to use something to make them feel well in this world. And as one of those people at one time that used substances to make me feel like I belonged, we have a duty to help people that need to belong, and then work on the other long-term, whatever societal conditions are there that they face. But in the short term, there's effectiveness in all of the data that's been put forward from all of the different safe supply programs, and listen to the voices of people who use drugs instead of unconditionally taking their voice, their trauma, everything they've been through, and just saying, no, we don't accept that. We have a duty to accept people for who they are, love them for who they are. That's what I say about harm reduction. Harm reduction is actually not actually saying, I'm going to meet you where you're at. On top of that is loving people for who they are and accepting them as they are. And we have a hard time doing that in Canada. And although the federal government has funded safe supply programs throughout the country, there's no continuity for our people. And so we need continuity. We need people to be able to step up and stand up for our rights. And so I would ask, I wish we were in a webinar that I could see everybody. How many people in this room actually drink alcohol? Can't see any hands, but I want to say a lot. Oh, Corey, I can see. Remember, in the early 1900s, it was illegal. And so anybody that drank that substance would be criminalized. And so the very fact that we would accept this to happen to our community is wrong. And I think I'll end with this. The definition that Einstein said of insanity is doing the same thing over and over and expecting a different result. Thanks.
Thank you so much, Natasha. Really, really appreciate your thoughts. And I wanted them to be the opening thoughts because we really believe that any conversation needs to be centered around people who use drugs rather than other actors. I'm going to hand it over to someone who is very, very closely involved in running one of the Canadian safer supply programs that are currently in existence right now. So over to Corey Ranger, who's joining us from the West Coast, a nurse background, registered nurse and clinical nurse educator for the Victoria Safer Initiative and the president of the Harm Reduction Nurses Association. Over to Corey.
Thank you so much. Can you hear me okay? Wonderful. Yeah, getting used to that CNE role. I previously was the clinical nurse lead, and our new clinical nurse lead is on the call today. So hello to Carissa. So just like Natasha and Janetta, I want to make sure that I start off with a land acknowledgement. We here at the Victoria Safer Initiative work on the lands of the ʷəŋən people, lands who continue to be violated by colonization and whose people continue to resist ongoing genocide. We honor the life force of the territories and the people of these lands, including all Indigenous people living on these territories who have been forcibly displaced. Ending the overdose crisis is deeply connected to decolonizing work. I also want to make sure, as Janetta also pointed out, just in the transition from Natasha and I speaking, that the work that I do here at the Victoria Safer Initiative, all of the work that we do here at Safer and at the Harm Reduction Nurses Association, and every field and pocket of harm reduction was born on the backs of people who have lived and living experience of criminalized drug use. These are the individuals who took the most amount of risk in order to innovate needle exchange programs, needle distribution programs, safe supply programming, naloxone distribution, and everything to do with harm reduction programming. And so without them assuming that risk, we wouldn't be able to talk to you about the program today. We wouldn't have nearly as many innovations in the toxic drug supply crisis as we do today. And so thank you for that. The Victoria Safer Initiative received funding from the federal government through the Substance Use and Addiction Program in June of 2020, and we were given 10 months of funding to develop, implement, and evaluate a flexible model for safe supply. And if you heard the incredulity in my voice, that's because 10 months is not enough time to do that kind of work. And that speaks to the problematic funding nature that we often experience in pilot studies and other types of programming, where it's really difficult to do the work. But we knew in the crosshairs of both COVID-19 and a worsening drug supply that we needed to get going right away. And so we started our clinical delivery right away, but we also partnered with Solid Outreach and the Canadian Institute for Substance Use Research to find out what people needed to see from safe supply programming in order to actually mitigate the harms of the toxic drug supply. And so we completed a series of concept mapping exercises where we asked people who use drugs for their feedback, and we asked them all one centralizing question, which is, I would access safe supply if. We asked people who were sleeping in parks, people who were in hotels, people who are Indigenous, First Nations, Métis, people who engage in sex work, people who use stimulants versus people who use down. And we asked them all this one question, and they gave us a number of responses that were then boiled down into 6 main concepts. People want the right drugs and the right doses for them. They want drugs that actually reflect what they're taking on the street. They want to be able to access services and be able to access additional services like housing options. They want to be able to access overdose prevention services. They want to make sure that they're not jumping through a bunch of regulatory and medicalized hoops. It includes being able to access carries, not having to be subjected to frequent urine testing, to be able to access drug checking services. They want to be able to easily get their safe supply and have caring prescribers who understand dope, who understand drugs, and who can actually speak to them and trust them and believe them when they share their experiences. They don't want to be labeled as a drug user. They don't want to be feeling like they're being judged. They want to be treated with respect, which unfortunately throughout the COVID-19 pandemic and before that, we've seen how disrespected people who use drugs have felt by their from interacting with their care provider. And most importantly, the last category here, people wanted a drug, they wanted an option that helps them function and improve their quality of life as defined by them. And I think when we're talking about medicalized safe supply, which has a lot of issues and a lot of barriers for people, this is one of the most important points because it's not about the priorities of the provider. It's not about the priorities of the prescriber. It's about the priorities of the person who is trying to access a safe supply. And if we can't uplift and affirm that, then we're going to be continuously putting out failed programs. Here at the Victoria Safer Initiative, we offer 3 different interventions. The first being a community option for tablet safe supply, either hydromorphone or oxycodone for opiate use, or Dexedrine, Ritalin, or Adderall for stimulant use. We also have a clinic which we opened in June of 2021, where we now offer fentanyl-based safe supply options based off of the feedback of people who have provided different surveys and focus groups for us. We offer injectable and sublingual sufentanil, which people can have up to 4 times a day, and they can also miss up to 30 days and still come back in and get a dose. We have a fentanyl tablet program, a dissolvable pill called Fentora, which people can take twice a day. And then we have long-acting options, which include traditional OAT, but also fentanyl patches for people. Our participants can be on any combination of the 3 options, so it's not one or the other. It's about tailoring according to what someone's drug use patterns are and what their preferences and goals are. We asked people before we opened our clinic how the program was helping them when we only had the tablet options, and 54% of our respondents reported that they've been able to reduce potential harms from substance use. 53% said that being able to experience positive social or health outcomes by their connection with our program. All of that includes reduced use of illegal substances, safer use practices, decreased cravings, decreased withdrawal, and a number of other benefits. Then we opened our clinic, which doubles up as an overdose prevention site. We are a legally sanctioned overdose prevention site here in Victoria. And since we opened our clinic and have been able to offer fentanyl-based safe supply options, our stats have improved significantly, with 73% of respondents reporting reduced use of illegal substances, increased connections to healthcare, and less reliance on the street economy. And we are busy. We're a small program, we're a small clinic, and so this is just a little bit of a snapshot of what it looks like in a day at Safer. So we had a busy day just a few weeks ago, and we tried to record it. We had 30 individuals who came to the clinic, 65 doses of 65 drug dispensations happened, 43 doses of sufentanil, 8 people received their fentanyl tablets, and 10 people got their fentanyl patch changes. We've been able to support currently have about 110 people that we're doing active case management on, and have connected over 200 individuals to a safe supply here in Victoria. And we also wrote all of our guidance documents and prescribing protocols because we know that the work needs to happen outside of small programs and outside of small pilot studies. It's very dangerous to do this work just in isolation. And so the next phase of our work is to try and build capacity with other jurisdictions and other prescribers so that they can start doing this prescribing, and we can build a community of practice, and we can start to see this scale up so more people can have accessibility. And this is just a little snapshot of our very rapid timeline where we went from engaging with people who use drugs to running services. And now we're at step 6, where we're engaging with developing a knowledge translation and exchange team where we can actually help other communities and organizations start to do this work so it doesn't get gate-kept out of one small clinic. Thank you very much for listening to me, and I'll stop sharing my screen now.
Thank you so much, Corey. So again, a different perspective, differently shaped program. I mean, there's a broad variety of different programs running across the country. I'm going to turn it over now to Tara Gomes, who is a researcher in Ontario. And just to get her perspective as someone who's been evaluating these programs, as well as what's going on the ground in Ontario. She's the director of the Ontario Drug Policy Research Network and holds a Canada Research Chair in Drug Policy Research and Evaluation. Over to Tara.
Thanks so much for having me. Really happy to be on this panel today and to already hear the 2 great presentations that have happened. As Janetta mentioned, what I'm going to do is present a little bit about the context in Ontario and specifically some of the work that we have been doing to try and understand safer supply provision and to evaluate programs occurring there. Before I start, I'll just acknowledge as well that the work that I do is done on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. Just to echo and build on what Natasha mentioned in her her presentation, you know, one of the real underlying reasons why I think that safer supply is one of the approaches to the overdose crisis that is so urgently needed right now is this trajectory that we have seen in opioid-related deaths across Ontario, which is mirrored across many parts of the country, which is that we did see, you know, the slow build of overdose deaths in the late 90s and early 2000s. But in 2016, when in Ontario, fentanyl really entered the unregulated drug supply, we started to see that accelerate. And then, you know, as many of us were concerned when COVID came along, those rises accelerated even further. We saw in Ontario an 80% increase in opioid-related deaths just in the first 8 months of the pandemic. And you can see those 2 pandemic years in this figure, how much higher the rates of opioid deaths were just in those 2 years, since we've been grappling with the combination of both the overdose epidemic and the COVID pandemic. And what's so important, I think, for us to think about within this context is is what Natasha mentioned, which is that this is primarily a fentanyl overdose issue. This is one where during the pandemic, we've seen nearly 90% of opioid-related deaths where fentanyl is the direct contributor, and it is primarily the only opioid that is the direct contributor to these deaths. However, we're also seeing that there is a large degree of presence of other drugs because of how volatile and unpredictable the drug supply is. And we're really seeing the devastating impacts of the benzodiazepines that have now entered the supply. During the pandemic, again in Ontario, we saw that a quarter of opioid-related deaths also involved atizolam, which is one of the benzodiazepines primarily found within that drug supply, and about half of opioid-related deaths involved benzodiazepines more broadly. So this is not only a fentanyl crisis, but this is also one where the unpredictability of the drug supply is really contributing to the complexity of addressing this issue. And it's why people are demanding that they have a way of knowing what substance it is that they are using. And that is really what underlies, at least to me, much of the rationale around why safer opiate supplies are needed right now. And, the other element of this is that when we've looked at the deaths that have occurred during the pandemic, about a third of them happened in people without a diagnosis of an opioid use disorder, which again reiterates the fact that OAT alone, while a very effective option for people, cannot be the only option, because many people who are experiencing the harms of this unpredictable drug supply do not have an opioid use disorder diagnosis and won't be benefiting necessarily from OAT. In Ontario, for the safer supply programs that exist, they're primarily funded through the Health Canada SUAP funding. We have 6, to my knowledge, most of which are already up and running or are just about to get started recruiting patients. However, we also know that there are individual physicians who are working outside of these larger programs who are prescribing safer supply to maybe 1 or 2 of their patients. And so some of the questions we've been asking in Ontario are, how is safer supply being provided? Is it just in these 6 or so large urban centers, or are there other physicians who are prescribing this, and to what degree are they doing that? And how does the way that safer supply is provided by a physician who's maybe providing it to 1 or 2 patients differ from these larger programs? And then beyond that, trying to understand those benefits and potential risks for people who are engaging in these programs. So the work that I do is really reliant on health administrative claims data, which is essentially just that health record that is made anytime everyone visits a doctor, goes to a hospital, gets something dispensed from a pharmacy. And in Ontario, an organization called ICES basically takes that data, encrypts people's health card numbers so it's no longer identifiable, but allows us at a population level to see how people are engaging and interacting with the healthcare system. And I'm fortunate as a researcher affiliated with ICES to be able to access that data. And so I've been collaborating with many people across Ontario to try and use that data to understand safer supply across the province. One study that was led by Samantha Young that just came out earlier this year used the pharmacy claims data to try and look at that trend in terms of uptake of safer supply and initiations in the program over time in Ontario. We used some of the guidance document and spoke with many people providing these programs in the province to understand how to define this. And we basically looked at anyone who was starting 32 milligrams of daily dispensed immediate release hydromorphone tablets for at least 2 of their first 3 days of treatment. They were getting other hydromorphone, but had indication of healthcare encounters for an OUD or a hospital-treated overdose in the recent past. And this really, when we looked at the data and tried to understand better, it really appeared that this was capturing people who are accessing immediate release hydromorphone for safer supply, which in Ontario is the primary way in which people are accessing safer supply. What we have seen is that back in 2016, when the first program opened in London, we were at a fairly low rate of people accessing these programs, but it really has ramped up since that time. And this study ended in the first quarter of 2020. If we extend it to the year or so after, when there was more Health Canada funding and more programs were able to open, we have seen that these numbers have increased even further. So we're seeing hundreds of new people starting these programs every quarter. The issue that I would say, though, is that we still only found about 450 people who access safer supply over this 4 and a bit year period that we studied. And that's really a drop in the bucket when we think about the thousands of people who are losing their lives to fatal opioid overdoses every year. And when we think of the tens of thousands of people accessing OAT and the even larger population of people who use drugs. So while this is accelerating, it is not coming close to meeting the needs of what we need to be providing across the province. The other element that we found was that there is a small cluster of prescribers, about 20% of all safer supply prescribers, who are responsible for the vast majority of initiations. And that's really where we have these centralized programs. But this also means that there are more than 100 prescribers out there in Ontario over this study period who did provide safer supply to one or two of their patients, who were not frequent prescribers, but were trying to provide this service to some of their patients. When we look at who is actually accessing through either of these avenues safer supply across the province, we find that in general, these are people who have fairly high comorbidity burden. There's a lot of people who have recently experienced infective complications from injection drug use, people who've recently had an opioid-related overdose. And these are also people who typically have engaged and received OAT in the recent past. In the last year, 3/4 of people who started safer supply from one of these kind of larger programs of frequent prescriber had received OAT in the last year. But we see that there's a pretty low engagement with primary care prior to starting safer opioid supply. And I think that's really important as well, because these are complex patients. They're people who have tried OAT a lot of the time, but don't have great engagement within the healthcare system. So this is a population that really needs services and needs access to alternative options like a safer opioid supply program. When we look at the characteristics of this prescribing, I'll just point out a couple of things from this table, which were that retention was quite high in the safer supply programs, particularly those run by people who were providing a lot of safer supply. It reached about 9.5 months, which is quite a lot higher than we actually see in traditional OAT programs. So I think that's a really positive thing. And the other element that we saw is that there's a high degree of co-prescription of OAT, which we see as Corey mentioned, is an element of the program that that he's part of as well, and is a backbone that we often see provided with safer supply across Ontario. So this really has helped us better understand what is happening with safer supply in the province, but what we also really need to understand is that impact on patient outcomes. So we've been working with the London program, which was a program that started in 2016 to link all of their clients to the health data we have to better understand their trajectories of outcomes prior to engaging in the program and after being part of a safer supply program. The London program primarily provides immediate release hydromorphone tablets on a backbone of OAT, and is provided within a community health center, so an area where they are able to provide comprehensive health and social services through an interdisciplinary team. They recently released a mixed methods evaluation and demonstrated through that people who've engaged in their program have reported that, the majority of them have reported that their fentanyl use has decreased and that they have lower numbers of overdoses and visits to emergency departments and inpatient hospitalizations. And this aligns very, very much with what Corey just presented as well, with the work coming out of Victoria. And similarly, through the qualitative work, we're able to show the stabilizing effects of people who are able to access safer opioid supply programs as well. What we wanted to do is build on this because oftentimes these studies don't have a comparator group. So some of the arguments that arise are that we don't know what would have happened if somebody hadn't engaged in this program. And so what we've been trying to do is expand on the evidence and information on that side. So what we did was we matched all of the safer opioid supply clients in the London program with other London residents who had an opioid use disorder diagnosis and were matched on a variety of sociodemographic factors. But we're not in the safer opioid supply program. So they're geographically and demographically very similar to those who are in the program, but they were not accessing those services. And we looked in the year prior and the year post involvement in the program among the safer supply clients to look at their changes in outcomes over time, and then did a similar analysis on the controls under the assumption that nothing would happen in the controls because they didn't have an intervention. And then we could see if anything happened among people who are part of the safer supply program. And we looked at a number of outcomes, including ED visits, hospitalizations, healthcare costs, as well as risks of infections as well. What we found in this study, it's just being prepared for publication right now, so I can't share the full details, but essentially what we have seen across all of the outcomes that we studied were significant declines among safer supply clients in ED visits, in hospitalizations and associated healthcare costs, as well as significant declines in incident infections as well. So across the board, we really saw the benefits of these programs without any indication of increased risks among people who were participating in these programs and in the outcomes that we could study. And when we looked at the match controls, there was no change. And so I think this really reinforces the benefits that we can see among people who are able to access these programs. But it also speaks to the fact, if you tie this in with the prior study that I mentioned, in that access is actually quite low and quite centralized in urban centers. So when we think about where to go from here, we need to, I think, remind everybody, and what I think is so important to make sure everybody remembers and grounds themselves in, is that what must be paramount in these discussions is preventing the enormous loss of life that we are seeing across Canada right now from this unpredictable drug supply. And this is going to require a multifactorial response, and safer supply programs need to be part of that. And as we think about that, we really need to consider the expansion of these geographically, but by supply type, which Corey mentioned in his program, how there are different opioids being provided, and think about how we can evaluate all of these programs to make sure we provide the best options to people across the country.
Thank you so much to all three speakers. So you've heard from a variety of different perspectives from across the country. I hope that this will inform the conversation here in Alberta.